Welcome everyone, and thank you for joining us today for session 3 of Pressure Volume Loops to Measure Cardiac Function. Today's event is sponsored by Transonic and will be a case study review of 4 PV loop applications. My name is Andy, and I will be your host for today's event, and as usual, before introducing our guest speakers, I will quickly review the webinar controls for everybody participating. There are 2 windows that will allow you to access important functions of the webinar. Please note that the arrow will allow you to extend into the preferences dialog box, and that in here you have questions and chat window. Please submit questions and comments via the questions panel to ensure that they reach myself. Now I include this slide for those that may be online with us but are having issues with their audio. So we'll just give them a moment to hopefully read these directions and get them online with us for the session. Okay. So before jumping in, I'd like to take a quick poll from the audience today. So please take the time to just fill out these questions, and then we'll move on to introducing our guest speakers. Okay, we'll just take a few more seconds here to get everybody's input. All right, thanks everybody. Okay, at this point I'll introduce our guest speakers. Today we have 4 scientists joining us to discuss various PV loop applications. Dr. Craig Emter is an assistant professor at the University of Missouri, Columbia, and will be reviewing a left ventricular model of heart failure in mini pigs. Dr. Robert Hamlin is a professor at the Ohio State University and scientific director of Q-Test Labs. Today he will be discussing the value of PV loops in drug discovery and evaluation. Dr. Timothy Hacker is the director of cardiovascular physiology core at the University of Madison, Wisconsin, and will be reviewing a pulmonary hypertension mouse model and the value of right ventricular PV loops. Finally, Dr. Philip Konechny, application scientist at Transonic, will provide a brief introduction to ventricular assist devices and explain how pressure volume loops are valuable in medical device testing. So at this point, I'll bring Dr. Craig Emter online. Dr. Emter, are you there?
I'm here.
Perfect. I'm going to hand things over to you, Craig. All right, we have you, so take it away.
Okay, good morning, everybody. It's really great to be here to get to talk to everybody today. I'd like to thank Transonic, InsideScientific, and Cole and Andy for having me here today to talk to you a little bit about how we use pressure volume loops in the left ventricular preparation, really to integrate coronary vascular function and myocardial function. And I'm going to talk to you a little bit about how we do that in a mini pig model that we utilize in my lab of heart failure. So I have a background in exercise and cardiac physiology, and so my lab is really interested in evaluating both exercise and novel pharmacological strategies to assess their efficacy as a means of treating heart failure. Now, we use in particular in my lab a model of heart failure that looks more like heart failure with preserved ejection fraction, or what many of you might have known as being classically referred to as diastolic heart failure. And we use an aortic-banded mini pig model to do that. It displays a lot of characteristics of heart failure with this preserved ejection fraction phenotype, including, as you can see, obviously from there, number 2, diastolic dysfunction. I think perhaps maybe most importantly is number 1, which is depressed left ventricular contractile reserve. So as you can probably tell from the name of this heart failure subpopulation, they appear to have normal systolic function at rest. However, they do have systolic dysfunction, but it only really seems to appear when they exercise or they get up to go climb the stairs, go to the bathroom, activities of daily living sort of thing. So our particular animal model does display this, and I'll show you some data later on in the talk where we use PV loops to kind of demonstrate this. These patients typically display a significant amount of left ventricular fibrotic remodeling, and also a lot of times concentric left ventricular hypertrophic remodeling. A lot of these patients are hypertensive, and our animal model also demonstrates those factors. We see a lot of increased natriuretic peptide levels in the ventricle, kind of a classic heart failure model, and we also see impaired mitochondrial function in these animals as well. So kind of to get to the point of why do we care about this particular heart failure subpopulation, well, when we look at classic treatment strategies for heart failure patients with systolic dysfunction, caused by a heart attack, a leaky valve, genetic cardiomyopathies, a lot of the treatments that we've used for them for years, such as beta blockers, ACE inhibitors, diuretics, they don't really improve outcomes for this particular subpopulation of heart failure patients. And that becomes even a bigger issue because about 50% of all heart failure patients show this resting, preserved, functional profile now. So there's a critical need to develop some treatment strategies for this patient population. So I'm going to talk to you a little bit about a study that we recently published last year in which we tested 2 hypotheses, and we tested them in treadmill-trained aortic-banded YEP10 mini pigs. And you can see over there on the right, you can see one of our mini pigs hopping up there, chasing a little bit of food to get on the treadmill to start running. And what we're really interested in looking at is, could our training protocol preserve the balance between how much oxygen the coronary vasculature is supplying to the heart and how much the heart's demanding? Typically, when you get some pathological remodeling in the heart, you get changes in ventricular wall tension, and that increases oxygen demand. Real classic physiology stuff. And then also, we've seen an increase in fibrotic remodeling in these pig hearts, and we wanted to see if, with exercise training, we could change that fibrotic remodeling. And as I'm sure most of you are well aware, it does play a role in diastolic dysfunction in heart failure. So we were very interested in that question as well. So what types of methods did we use? Well, today I'm going to talk to you a little bit about 4 in particular. Obviously, pressure volume loops. We do serial ultrasounds on these animals, so we do echocardiography every month to serially monitor their function over the course of our aortic-banding procedure, which we band these pigs for 6 months. We measure coronary blood flow, and we also measure myocardial blood gases as well to determine myocardial oxygen consumption. So really, PV loops to us, at least to my lab, are really essential to provide a comprehensive examination, because not only do these animals have diastolic dysfunction, but they also have systolic dysfunction. And it's not just the myocardium we think that's involved. We also think it's the coronary vasculature. We know that we have metabolic issues. And so we really want to be able to integrate all these particular things to give us a very comprehensive view of what function looks like in these animals. So here you can see, oops, I'm sorry about that. Hold on, get right back. Okay, here we go. Here you can see is a radiogram of our aortic-banding location and also hemodynamic status of how we set the band. So over here is the heart if you want to orient yourself, and then you can see the aorta trailing and through the ascending arch and then starting to descend. We have a femoral artery catheter that we run up through the band to measure transonic pressure gradients when we set them. We do our aortic banding on the ascending portion of the aortic arch, so you can see it's proximal to the brachiocephalic artery and also the subclavian here. And again, you can see the descending aorta here. So it's very localized increase in afterload really on the heart and the coronary vasculature and everything leading up to their lungs, right ventricle. You can see down here in our table that we are able to set between our groups. Here you'll see our heart failure group, which is an untreated aortic banded group, and our heart failure trained group over here, which is our exercise trained animals. You can see that we set a very similar transonic pressure gradient. We set it at a similar heart rate between all the animals, and we also maintain a similar mean arterial pressure peripheral to the band. So basically, we're setting this pressure gradient under equal hemodynamic conditions between all the groups, which is important. Okay, here I want to share a little bit more about our methodology, and here's one of our terminal procedures where we've done a sternotomy, and we've placed our coronary flow probe here on the left anterior descending coronary artery, and you can see it tracking off here in the white. We also have a custom-made venous catheter that we can sample venous blood from the great cardiac vein. And then also you can see our PV loop catheter, and we use an apical insertion in our particular prep because we feel like it really helps us optimize placement of the catheter and gets us the best signal for our pressure volume loops. Okay, so now on to some data that we've generated from these loops. On the right you can see some published loops that we did in control animals, our heart failure untreated aortic-banded animals, and then our aortic-banded animals that got heart failure and were exercise trained. And the first thing I want to show you is that, you know, when some of the data we like to generate is we're using the PV loop to integrate blood flow and metabolism. Or in this particular case, we're looking at cardiac efficiency. So that ratio is stroke work to myocardial oxygen consumption. And you can see here as I trace one of our biggest, most initial loops, we integrate that area to stroke work and then we normalize it to how much oxygen the heart's consuming. And here we can see in our exercise trained animals that even despite the pathological remodeling we're seeing, even in the heart failure group, although it's not significant, but with exercise training we're able to increase cardiac efficiency even in the face of a chronic sustained afterload. So again, we're able to integrate this, the pressure volume loop and some of our oxidative data from the heart. The second set of slides I want to show you, as far as data goes, is we do a lot of ultrasound in the lab, and we've been very recently getting into a lot of 2D strain measures, which is just basically looking at how the heart mechanically changes and moves during the course of a cardiac cycle. And one thing we see over here is that in our heart failure hearts, we see a decrease in untwisting at the level of the apex in the left ventricle during early diastole. We were able to preserve that with exercise training. One thing we can do is, instead of just totally relying on ultrasound, is there's been some studies that integrate measures we can get from pressure volume loops into those that we see with the ultrasound, particularly the 2D strain, and form very nice, very tight relationships. And you can see here that we've correlated that untwisting with both tau, which is an examination of the degradation of pressure during isovolumic relaxation, and also with left ventricular insystolic volume. So we're able to correlate it with diastolic function and also kind of the transition from end systole to early diastole. And you can see really nicely that in our heart failure group, you can see that as that increase in tau, which is considered a negative or an indicator of diastolic dysfunction, gets higher, we see a decrease in untwisting. That exercise, we were able to prevent that. And also with left ventricular insystolic volume, we see an increase in left ventricular insystolic volume in that heart failure group, again, indicative of some systolic dysfunction in this case, and a decrease in untwisting during early diastole that, again, we were able to kind of prevent with exercise training, or at least attenuate that decline. So again, we're using this pressure volume loops to integrate diastolic function from our PV loops and also our ultrasound measures. And then finally, I want to show you some contractility data. So here in this table, we're using pressure volume loops to assess left ventricular contractile reserve. If you remember, I told you these patients look fine at rest systolically. But when you stress them a little bit, they don't have that cardiac reserve. So we took two real classic measures we can take from pressure volume loops, including an systolic pressure volume relationship and also preload recruitable stroke work. And we measured them under normal resting or baseline conditions, as it's listed here, or in response to a beta-adrenergic agonist. In this case, we used dobutamine. And then we took a look at the change. How much could they increase in contractility? And that's where you see here contractile reserve. We saw in the heart failure group that it was indeed depressed, as you would expect in this particular patient population. We see that in our model as well. And with exercise training, we're actually able to preserve that contractile reserve. So as far as things we're able to conclude from the study, number one, we were able to see, hey, our exercise training protocol actually prevented diastolic impairment. And it wasn't just by one modality. When we integrated some of our measures, our ultrasound measures, our pressure and volume measures, we were able to detect some really interesting relationships using multiple modalities. So we weren't relying completely on one modality. We were also able to see that exercise training improved cardiac efficiency, again, integrating our pressure volume loop with our myocardial oxygen consumption measures. And then we're also able to see that exercise training was able to preserve left ventricular systolic functional reserve, which is important in these patients. That's what they really lack, is the ability to climb stairs, exercise, do activities of daily living. That's when we see the systolic dysfunction come out. So for us, these results are really meaningful because they truly do allow us to integrate functional and hemodynamic data from a lot of different methodologies. Okay, so we can look at coronary blood flow, we can use the PV loops, we can use our ultrasound, and it gives us a real comprehensive look into cardiovascular coupling. And I think that's important because I think too often as scientists, we're either studying the vasculature or we're studying the myocardium. And we forget to say, hey, these are really interacting in a meaningful way on virtually a beat-to-beat basis. And not only that, but it allows us to do it in the big animal setting of heart failure, which there's not a lot of labs in the world that are able to examine heart failure in big animals. So it really does help us get a comprehensive look as to what is going on in the heart in response to our interventions. So in summary, I just really want to reiterate again that I really believe that PV loops are essential to us, at least to providing a comprehensive look at systolic and diastolic function in an in vivo setting, and really allows us to integrate the myocardium, coronary vascular, and metabolic function of the heart in a way that we wouldn't be able to do without them. So as far as where the lab's going next, obviously we're an exercise lab, so we're going to examine exercise at different intensities to see if we can kind of optimize exercise as far as how do you prescribe it in a clinical setting, what type of exercise intensity really works best for a heart failure patient. And then there's also some clinical therapies that have recently, we've seen them an increase in their use for heart failure patients that we actually think could potentially, for this heart failure subpopulation, make them worse if they were to exercise. It could inhibit exercise benefits. So we're interested in examining that too. So in closing, I just wanted to invite all the attendees out there on the interweb to send questions specific to this application through the questions window, and I'd be happy to address them during the Q&A session. And I'd like to now pass things on to our next presenter, Dr. Robert Hamlin. Thank you.
I'm very appreciative of the opportunity of addressing this august group. However, I'm a little speechless from excitement over the preceding lecture. I found it just fascinating. Nonetheless, I'll try to go ahead and address some comments that we have gleaned from studies we've done at OSU and Q-Test labs and other places. I'm addressing this in the context of my being a clinical cardiologist, a clinical investigator, a safety pharmacologist, and one who has also been a subject on phase 1 clinical trials. There's a few things that I feel compelled to know about test articles, drugs or devices, before investigating them. I feel it's very important to know the effect of the test articles on at least 16 specific parameters of cardiovascular function. The properties of the test articles are well known, and the reason they're important functions is because if affected by a test article, we know very well that they translate to morbidity and or mortality. So as I ask people who solicit our help, when they say, well, what should we measure? I say, don't tell me what you want to measure, tell me what you don't want to measure and how you're going to deal with the consequences of not knowing information that might cause either financial harm or harm to a reputation of a pharmaceutical house, for example. So there are a number of essential measurements that are outlined in this. They're pretty standard. We must know about electrophysiological properties, hemodynamic properties, pressures. And when we talk about pressures, it's not just mean arterial pressure. There are really 4 arterial pressures that are important: systolic, diastolic, mean, pulsatile, and late systolic accentuation, which are really important in determining outcomes and responses. We must know myocardial contractility. It was pointed out in the previous presentation, we must know lusotropic properties because 50% of the morbidity and mortality from heart disease stems from abnormal diastolic function, not systolic function. And as was also pointed out in the previous lecture, it's important to know about myocardial energetics because we know that a lot of test articles produce morbidity and mortality not because they're cytotoxic, but because they produce energetic imbalance. So before we begin then, let's remember that a good animal model shares with man the physiology and pathophysiology of target diseases. We must know what those differences are, and we must accept the fact that animals are surrogates for man, not perfect, but neither is a man perfect for surrogate for another man. So, what properties does a drug affect? Studies in safety pharmacology are usually conducted measuring left ventricular pressure, not left ventricular pressure commonly, but systemic arterial pressure, but nowadays more people are measuring left ventricular pressure as well. So in a typical safety pharmacology study, there are electrocardiograms and aortic pressure is measured, and occasionally left ventricular pressure. The question is, does this tell you what you want to know? Now in this trace, you can see at the red line, the subject was exposed to a test article. And you can see clearly from the left ventricular pressure pulse that the systolic pressure fell after dosing, the aortic pressure fell, and notice the very interesting finding that the systemic arterial pulse pressure towards the end actually increased. That is, the difference between systolic and diastolic was greater, implying that diastolic pressure fell more than systolic pressure. So now, what properties does this drug possess? Well, we want to know, does it affect inotropy, myocardial contractility, the velocity of cycling of heavy myromycin heads? We want to know, does it change heart rate? Very importantly, we want to know, does it have a lusotropic effect? Does it change ease of filling? And we know that filling occurs not during the rate of fall of ventricular pressure, but the ventricular filling occurs after the pressure has fallen, after dPdT min occurs. So neither tau nor dPdT min are, to our mind, adequate surrogates of lusotropy. We also want to know, since we know that the left ventricle does not pump blood through the arterioles, but rather pumps it into the first portion of the aorta, that is, the arterioles are too far away from the ventricle to pump blood through it. So we want to know the hindrance to ejection of a test article imposed by its effect on the arterioles, that's distally, systemic vascular resistance, and on the aorta, which is reflected by the impedance. And of course, we want to know energetic imbalance, that is the oxygen delivery minus the oxygen consumption, as was addressed in the previous discussion. Well, how about dPdT max, or dPdT min, obtained from the left ventricular pressure curve? dPdT, of course, is the rate of change of pressure. It is determined by three factors: inotropy, preload, and afterload. So when it changes, we must ask the question, why did it change? Did it change because of the rate of cycling of heavy myromycin heads? Did it change based upon the number of heads cycling or avidity of calcium to the troponin, preload that is? Or did it change because the hindrance to ejection, that is the function of the ventricular arterial coupling? We must know the effect of the test article on all of those parameters, because a change in any of those parameters may translate to morbidity and mortality. So we're usually asked to obtain dPdT of the pressure curve. So now you're looking at the top trace, left ventricular pressure, the middle trace, the rate of rise or rate of fall of left ventricular pressure, that is the rate of change of ventricular pressure, and the bottom trace, the aortic pressure. And you can see from these curves that you already knew that left ventricular peak systolic pressure fell. Diastolic pressure did not change substantively. That aortic pressure fell, systolic, but diastolic more, and the dPdT max fell and dPdT min elevated. So what do we know from analysis of that curve? Do we know any more about contractility? No, because all of the parameters measured are affected by preload, afterload, as well as contractility. So we don't know the effect of the test article on contractility. Now, you know well, the people participating in this discussion, you know well what a PV loop is. You know how it is generated. You know how families are generated during a heterometric autoregulation curve. You know how to identify end systolic pressure volume points. You know how to develop points for preload recruitable stroke work. You know how to construct a line and to calculate the slope of the line connecting the end systolic pressure volume points during the heterometric autoregulation maneuver. And you know that the slope of that line is considered the gold standard for estimating myocardial contractility. I don't say it is preload independent, although it is preload dependent, because contractility cannot be measured unless both preload and afterload are known, and we believe that pressure volume loops are good for this. So we ask the question, what are the properties of this test article? And the other question, very important to the pharmaceutical industry, what are the consequences of not knowing these properties? So what are the properties again? Inotropy, velocity of cycling of heavy myromycin ends, chronotropy, heart rate, lusitropy, ease of filling, and remember, lusitropy is manifested twice. It is manifested dynamically as the ventricle fills, that is the slope of this filling line, and is expressed statically as the ratio of end diastolic pressure to end diastolic volume. One of these, the filling, actually occurs after dPdT max occurs. dPdT max measures, or dPdT min, measure the rate of sequestration of calcium from the troponin to the sarcoplasmic reticulum before any filling occurs. But the PV loop measures the lusitropic properties during the time that the ventricle actually fills. Very, very important. And remember, since the ventricle does not pump blood through the arterioles, we want to calculate arteriolar resistance, and we want to know arterial hindrance, the hindrance to the flow of blood into the aorta. We also want to know about energetic imbalance. Okay, fine. Now, from an analysis of the aortic pressure, the left ventricular pressure, and from dPdT, you would have predicted, I might add incorrectly, this test article that we're going to talk about now was a negative inotrope. You would not have known it constricts the aorta, you would not know it improves energetics, and you would not know it possesses no effect on lusitropy. So let's take a look at the PV loops. Now remember, the blue PV loops are a family of loops obtained during heterometric autoregulation when we decrease the preload. We know that the slope of the curve connecting end systolic pressure volume points represents myocardial contractility. Then this rat was given a test article, we won't tell you what it is yet, in which you can see that the peak systolic pressure fell, the rate of rise of pressure fell, you saw from the dPdT slope, yet notice that the stroke volume increased, that the myocardial contractility increased, all in the presence of no change in lusitropy, that is the filling and both dynamically and statically at the end diastolic pressure volume curve point were the same. So we know that this is a positive inotrope because the slope of the line was greater after treatment than before treatment. We notice that there's no lusitropic effect because of the filling properties. There's no change in heart rate, which we didn't get from this, but we got by merely counting it. We know that that there was arteriolar dilatation because we can calculate that quite easily from the ratio of arterial pressure to to cardiac output of stroke volume. We know that there's arteriolar constriction for reasons that we'll show you shortly. We know that the stroke volume went up, that there was no change or little change in preload, and that the energetic balance actually went up. That is to say, the ratio of oxygen demand to oxygen delivery went up. Now, how do we know that? Because we extrapolate this line back to the so-called VD. We measure the area under this curve, and that area relates very intimately to myocardial oxygen consumption. You see that before we gave the test article, oxygen consumption was greater than after we gave the drug. So again, the drug is a positive inotrope, no chronotropic effect, no lusotropic effect, arterial constrictor, arterial vasodilator, arterial constrictor, and there's an increase in stroke volume, improved energetic balance. So we glean that from this data. Now, the value of PV loops, and then we'll expand on that data. Quantifying inotropy and lusotropy, both dynamically and statically, measuring stroke volume and cardiac output, including the end diastolic volume and end systolic volumes, quantifying aortic and mitral regurgitation and shunts through an interventricular septal defect. This is, I say as a clinical cardiologist, I would like to know, and we glean that from the curve, not shown here. And we can calculate determinants of myocardial oxygen consumption. Nothing comes close to providing the useful, important information generated by the pressure volume loop. So, in the big picture, the pressure volume loop data can affect your decisions to advance a test article. Drug houses want to know this. Clinical investigators want to know this. Patients who are on clinical trials would like to know this as well. Top administrators, clinical investigators, and venture capitalists want to know it because they want to know what to do with a test article. And don't subjects or patients deserve it? What does he require to obtain pressure volume loops? Technology, surgical competence, time and effort. In our experience at Q-Test, it takes about 2 days. It costs less than $18,000 or 12,000 pounds. So we believe that this is a good investment. Now, I'd like to get back to our
I was going to say,
loop, and
thanks, Dr. Hamlin. That was excellent. If you don't mind, yeah, I'm just going to launch our next poll. So that was very informative, and your final slide there did an excellent job on summarizing the main point here and the bigger picture in pharma and the investment, to have the data that we need to move forward with confidence. So thank you very much. Again, to our audience, I'm going to launch a quick poll. And so what we'd like to know is, what tools and techniques do you currently employ to study hemodynamics and cardiac function? Please select all that apply. And then we will move on to our next speaker, Dr. Tim Hacker. So Tim, I believe we should have you online now.
Yes, I'm here.
Perfect. Okay. We hear you loud and clear, and I'm just going to give a few more seconds for our audience to chime in with our poll, and then I'll hand things over to you. Okay. Thank you, everybody, for your input. And at this point, Dr. Hacker, I welcome you to continue.
Thank you, Andy. It's been a great session so far, and hopefully I can continue that here. Today I'm going to talk a little bit about doing PV loops on the right ventricle side, so a little bit different and certainly equal as important. We're measuring some of the same things that the two previous speakers talked about. Today we're going to use a little bit different model, and I'm not sure why my computer's not advancing. Can you see my screen?
Hi, Tim. Andy here. Just want to check that we do see you.
Okay.
We've got your introduction slide.
And
are you having issues advancing forward through the slide deck?
Yep.
Okay, I'll come in and let me see if I can do this for you. So just to everyone watching, just give us a moment here. Appreciate your patience. Okay, and now we should have you. Okay, take it away, Tim, and just go ahead and tell me to advance slides.
Okay.
When ready.
Why don't you go to the next slide? So the model that we are looking at as we're trying to develop is a pulmonary arterial hypertension model in mice. And pulmonary arterial hypertension is really marked by arterial remodeling, particularly stiffening of all the arteries and then occlusion in the small distal arterioles. It's a disease that has a median survival of only 2.8 years, and current treatments target vascular changes, but the outcomes are still poor, and so there really needs to be new treatments developed to try to get at this disease. Okay, next. Next slide.
Yeah, you might experience a delay here, Tim.
Okay.
There you are.
So what we're trying to do is, again, develop this pulmonary arterial hypertension model in mice. If you look at the graph on the slide, as you can see that it leads to RV pressure overload, which increases wall stress and eventually myocardial remodeling. The remodeling early on is adaptive remodeling, and then at some point this adaptive remodeling goes to maladaptive remodeling. Hearts dilate and fail and go back to increased wall stress, and this sort of insidious cycle keeps getting worse and worse, and there's no ultimate treatment other than heart transplant. And what we're really interested in is looking at what the molecular mechanisms are that govern the transition from adaptation to maladaptation. Sorry. All right, next slide. So our goal here is to measure, to develop a model of pulmonary arterial hypertension that transitions from a compensatory RV remodeling to a right heart failure. And to do that, we're going to measure PV loops, and then hopefully what we'd like to be able to do in the end is develop a mathematical model to simulate what we see physiologically. Next. So our model is pretty simple. We treat mice with 10% hypoxia and then with a VEGF inhibitor Sugen to potentiate the hypoxia. And the mice are treated either for 14, 21, or 28 days. We measure right ventricular pressure volume loops. We also have been looking at these mice by echocardiography, looking at wall thickness, tricuspid regurgitation, and pulmonary artery blood flow. These are sort of standard things that they would look at clinically. And then ex vivo, we take these arteries out and look and measure some viscoelastic measurements, as well as look at isolated myocytes and cross-bridge kinetics. Next. So here's a classic PV loops that you guys have seen several times today. The dotted lines, the smaller loops, are the normal right ventricular PV loops in these mice. And after 28 days of hypoxia, they have some significant increases in pressure, and you can see the loop is shifted to the right, again showing the greater end diastolic and systolic volumes versus normal. Next. So some of the data that we see is that, of course, we're measuring contractility. The thing that we're mostly interested in is if you look at end systolic elastance, you can see that it increases from the control animals, the normoxy animals, to 28 or to 14 days of hypoxia. It continues to increase after 21 days. So this looks like some adaptive physiology, and then finally at 28 days it starts to drop. If we look at preload recruitable stroke work, another measure of contractility, we see very similar curves. If we look at dPdt max, something similar but not nearly as dramatic as drop after, well, we see it leveling off and then an increase again, and so not really telling us where this transition from adaptive to maladaptive physiology is occurring. Next slide. If we look at ejection fraction, and these were obtained from the PV loops, but we could also potentially obtain these from echo, you can see that there's just a steady decline in ejection fraction. Cardiac output is a little bit more illustrative of looking at the adaptation from adaptive physiology to maladaptive. Again, it goes up after 14 days of hypoxia and then slowly drops, but still doesn't go back to normal. Next slide. If we look at the pulmonary vascular resistance in these animals, also we can measure this through the pressure part of the PV loops. We have a continual increase over longer periods of hypoxia. If we look at the elastance of the arterial elastance, we also see this continued increase of elastance as the hypoxia continues. If we look at the ratio, so we're looking at how the vascular couples to the ventricular performance, and this is probably most illustrative to us about when these hearts are going to start to fail. So again, we have some improvement in this ventricular vascular coupling after 14 days, and then it slowly starts to drop after 21 and 28 days. And so all these measures combined really help to tell us where the difference between adaptation and maladaptation occur. Next slide. So what we see in our hands is only pressure volume analysis shows when the RV is going to start to fail. And again, the PV analysis shows this initial increase in contractility. We see it increases in end-systolic elastance and preload recruitable stroke works, and then decreases. And we also see these same initial increases in the ventricular vascular coupling and then decreases. When we've looked at other measures to compare how well the PV loops do to other measures, we really don't see this transition. If we would just look at RV pressure, we only see a continual increase in RV pressure. If we look at ejection fraction, again, we just see this continual decline. If we take the hearts out and actually measure the RV mass continues to increase, so again, not a good measure for us to look at this transition. We've done extensive echo measurements on here, and we don't see changes in tricuspid regurgitation. In fact, in mice, we rarely see tricuspid regurgitation in pulmonary hypertension, whereas it's fairly common in people. We see a fairly continuous increase in RV wall thickness, and it's possible that we see that because the echo is probably doesn't have enough resolution to discern much changes in there. And then if we look at pulmonary artery velocity acceleration, which is another measure done clinically, we see these continuing increases, and you can look at these images on the left and see at normoxia the acceleration is far less steep than at 28 days, and the time to peak is again much shorter at 28 days. But this is a continuous process, so it's not really going to discern between adaptation and maladaptation. Next slide. One of the things that was really interesting to me is we were able to take this PV data and make a mathematical model of it, and we used 26 different inputs, most of it again gathered from the PV data, and found that in order to make this model work, we had to have a significant increase in the stiffness of the right free wall at 21 days compared to 14 or 28 days, as compared to the value at normoxia or 14 or 21 days. And when we measured the collagen in the right free wall, we found it to be significantly increased also at 28 days compared to 14 or 21 days. So this PV data became very valuable to us to not only model this situation, but actually be able to predict what would happen if we change some of these inputs. Next slide. So again, for us, the PV loops were critical to determining the change from compensated to decompensated RV function by echocardiography. We didn't have a similar delineation And the next step for us would be to compare the global function by PV data to ex vivo vascular and isolated myocyte changes. And we've done some of this work already, and I don't have a lot of data to show you, but we've definitely seen matches. And so I think going forward it's possible that this PV data will eliminate doing some of this isolated myocyte changes and ex vivo vascular work and save us some more time in the end, because it seems to give us enough information to define our models. So with that, I'd say thank you. I invite all attendees to send questions specific to this application through the questions window. And I'll now pass things along to our next presenter, Dr. Philip Konecny.
Thank you very much, Tim. And Philip, we should have you. Perfect. We can hear you loud and clear.
On.
Yes. Take it away.
Thank you. Thank you, Dr. Hacker. Very interesting data you have presented. I'll take on right now and follow the lecture. My name is Dr. Konecny. I'm an application scientist with Transonic Systems, and I will be presenting today for about the last 10 minutes of this PV Loops series. My presentation will be about the synergies of PV loop and left ventricular assisted devices. So let me move quickly from this slide to my second slide, which is what is a ventricular assisted device. I'll move through a couple slides very fast. This is for the audience basically, and last two slides I have a real interesting data to share with you. So for the second slide in mind, on the right side you can see, as you may know, most of the LVADs are composed from, as you can see, pump, controller, tubing carrying blood out of the heart chamber to controller, and tubing carrying blood to the arteries. There's also power source included. So as you can see on the image, there's a transonic flow probe. So Transonic has a long-standing relationship with VAD companies, ventricular assisted devices companies. So what we really want to present today is the synergies of the PV loops and basic LVAD or VAD application. So what we have is LVAD, which is left ventricle to aorta or any major artery. And we can also have RVAD, which is RV to PA, which is used only for short term. There's also VAD named BiVAD or total artificial heart, TAH, which replaces both chambers with the pump. Let's move quickly to the third slide, where I present I'll touch upon briefly on two additional VAD characteristics. First being when VAD is used, it's used on three major occasions. So as you can see on the bottom of the slide, it's used peri or post-surgery, and we call that, for example, in post-cardiotomy or during arrhythmias. We can also use VAD as a bridge to transplant or destination therapy. So moving from that, we see the first characteristic on the slide on the top. VAD is based on the placement. So we see that there are two types of the VAD. One is percutaneous, pump is located, and also the power source is located outside the body. And there's also VAD, which is called implantable, which is mobile. So VAD is implanted. Let me move further and introduce another global challenge and objectives of VAD as a device, medical device. So there are two broad divisions, as you can see on the slide. So when is VAD used? So the VAD is used preclinically for preclinical testing, but also VAD is used as a post-clinical testing. So the preclinical testing, it's usually the early stage of testing to characterize the device on its own and to optimize its performance. The post-clinically, it's used for evaluation and approved device for continuous improvement and study in specific disease model. What does that mean? It's, for example, it's known, common knowledge that LVAD implanted, it may cause right ventricular failure down the road. So post-clinical testing is very important as a challenging in this medical device testing. In both cases, the main objective to study that, it's ventricular unloading of injured myocardium, it's a sustained organ perfusion, blood oxygenation, and diuresis. So the global overreaching goal is to balance the hemodynamic support with minimal heart energy demand. Okay, so let me move to the next slide, and here I will briefly touch upon a couple of characteristics and system to monitor LVAD in the research setting. So as a first monitoring device, you can see the flow probe, basically the flow system with the full built-in flow probe in the VAD device. That would be the best I can envision. The second, to monitor LVAD, I would put as a pressure catheter, as a pressure measurement, because we know, as we talked, as we see on the previous slides, the aorta would be the basic area. I would put the micromanometer pressure catheter to monitor all volume or pressures, and opening and closing, for example, aortic valve, very important message. And also I would put the pressure catheter at the periphery, and I would use it to monitor excessive pressure, as we know they might develop in the system when the pump is unbalanced. So as a third device I put here, it's a Schwann-Ganz catheter. As many of you know, Schwann-Ganz catheter is widely used catheter in the field. As I put here, approximate cardiac output and pressures. I would put the pressures mostly on the right side, also central venous pressure, right arterial pressure, venous pressure, ventricular pressure, and pulmonary artery pressure, and also monitoring of the PCWP, or pulmonary artery occluding pressure, and you can monitor left atrial pressure because there is no valve in between. So the fourth item is EKG for monitoring LVAD, and for EKG, continuous monitoring helps monitor the valve function and timing. That's very important to live stream it with other devices if you include pressure catheters and flow probe. EKG is necessary. Fifth is continuous PV loops, and that's the synergy here. It's a real-time measurement, beat by beat, and it's monitoring left ventricular unloading. As we remember from before, we're looking for the balance unloading, and that's the purpose of the pressure volume loops inclusion into that group. So are you about to influence hemodynamic parameters? It is warranted to monitor central and peripheral blood pressure and volume to prevent suction on the system and blood stasis and congestion. So here is a couple things to really, this is wrapping up really the introduction. And here what I have learned, I'm introducing the challenges of LVADs. So what I really seen so far, it's the ideal VAD provides perfect balance. So in reality, resulting hemodynamics would fall somewhere between the under-accomplished or an excessive support, and will vary depending on the heart and device function. So in the middle, you can see balanced conditions, which encouraging the cardiac recovery and decreasing apoptosis, reducing the infarct size. But you can also have an inadequate unloading, which is on the left side. So in that box, you can see really what's happening if you have inadequate unloading. You have, for example, aortic regurgitation. You have hemolysis. You have a thrombolysis in the system, thrombosis, and LVAD. It leads sometimes to LVAD failure. On the other hand, you can have excessive unloading, which is on the right side, and you may develop possible suction, which may lead to post-LVAD right heart failure. That's one of the downsides of unbalanced condition. So as we know, it is important to stress that how the PV loops are monitoring. We all have to understand when we model that situation in the lab, we have to achieve the disease state. On my next and last two slides, I will show you how PV loop is used to monitor of the disease state progression, to establish a true baseline for LVAD implementation, and how PV loops can be used to monitor two conditions. One being a steady-state PV loop, and this is the slide, and the second being the transient preload reduction for disease state condition and LVAD application. So slide number 8 introduces concept of PV loop application post-LV injury. So as you can see, monitoring of the baseline, which is the orange PV loop on the left, is very important. So as the heart becomes injured, the PV loops shift to the right as we on the x-axis. So the post-acute injury green loop you can see there. So as we've seen many times, and Dr. Burkhoff presented in the earlier sessions, how the PV loops changing position based on the injury, and what's the characteristic of the injury and PV loop change. There is, however, no unloading, and it leads to the blue loop, which is the not unloading, and it's failing heart. So when we see that based on these, this is animal captured all exams, we now employ the LVAD. So the LVAD is the red dashed PV loop and describes the situation of balanced unloading of injured heart, and it leading to encouragement of cardiac recovery, which nicely tie up everything together. So this is the balanced recovery, and decreasing, for example, apoptosis, infarct site, and for example, these are the most examples I can think of right now. So as the red dashed line moves, making its way to the left, you can notice ESP is decreasing, stroke volumes decreasing, and then stroke work also is decreasing. So this is compared both to green and blue PV loops, and this is basically the situation of balanced unloading. So on my last slides, so it will be slide 9, I'm introducing concept of PV loop and a transient preload reduction during the states of injury and post-unloading of the LVAD, using the LVAD. So in this concept, I'm using the micro oxygen consumption, or known as MVO2, to explain the situation. Here, I want to step back and use a minute to explain PVR and MVO2 correlation in the heart. So as we know, to maintain a cardiac contraction, conversion of the chemical energy to metabolic substrate into mechanical energy is essential. As for a heart and cardiac energy demand, it has a relatively low content of ATP and the creatinine phosphate. Both has to be generated at high pace by heart. So the cardiac energy consumption can be estimated by measuring oxygen consumption as a surrogate. As for that mechanical efficiency in hemodynamics, known as pressure volume area, or PVA, it represents or better correlates with MVOT. As for more than 95% of ATP is produced by heart, and it's consumed by heart. So PVA represent and share between PV or PE and SW, which is the stroke work, and P as a potential energy. So both are in joule. So as you can see on that last slide, number 9, after the transient preload reduction, the highest consumed energy is by heart, that is post-injury, green or blue PV loop. Second highest metabolic demand or oxygen consumption comes from the orange PV loop, that is the baseline state. And the lowest metabolic consumption comes from the red dashed PV loop, which represents the successfully unloaded, balanced unloaded LV. So the PV loop in this setting is able to predict and compare, that's the important point here, and compare how good is unloading using different left ventricular assisted devices. Okay, so in the interest of time, at this point I would like to hand the control over to Cole McClarty for his final comments and Q&A session. Thank you very much.
Thank you, Philip. Hello, everyone. As Philip mentioned, this is Cole McClarty. I'm the National Training Representative for PV Loop Solutions at Transonic. As we're amalgamating and organizing your questions for our brief Q&A session, I wanted to take this opportunity to thank our speakers again today for their insight and time. Together, we are hoping that from this case study review, you're able to take away the following. From the left heart, PV loops are essential for interrogating both systolic and diastolic function. PV loops allow us to elucidate
complex drug interactions through load-independent measurements. For the right heart, PV loops provide insight into functional compensation through various stages of pulmonary distress. And through transient load restriction and cycle-to-cycle assessment, LVAD testing can be improved. Following this meeting, there's going to be several additional resources for learning that are going to be available to all attendees at InsideScientific.com. Links to these resources will be sent to you following this presentation. Here you can expect to find the slide deck and recording for this entire review, so you can go back and re-review everything that you learned today. The question and answer period, which we will get to shortly, and also will include a little bit more complex answers from our panel, will be available within the coming weeks, so certainly visit back at the website for that. As well, you can find surgical training videos and more. Most importantly, Transonic's very proud and excited to announce our 5-part pressure volume ebook series. This is something that we've been working on over the period of about a year and a half. And it's over 100 pages, and what it does is it amalgamates all of the questions that we've been receiving, and I've specifically been receiving over the past 5 years. There's been a lot of uncertainty in this industry on the technology and the theory and the equipment needs and applications and specific surgical protocols, for example. And so what we've done is we've collected all this information from clients and leaders in the field and put it into one source. And so we're launching that actually today. You'll be the first group that will be available to download this resource, so we hope that you'll have the opportunity to review that. And as a final reminder, over the course of this ongoing series, Transonic will be partnering with leaders in education and industry like we did today to provide you answers to an eclectic mix of topics that you personally have requested. For specific case examples outlining the importance of pressure and flow synergies, for example, or to more broad topics such as how to set up a core lab, which is a very fundamental question but is very complex, we're going to be inviting core leaders back to discuss this, and we hope you can join us. I'll now hand things back to Andy so we can start the question and answer session.
Thank you, Cole. And I'm going to bring all of our guest speakers back onto the line. So everyone chime in just so I know you're with us.
It's Craig. I'm here.
Perfect. All right.
Tim is back live.
Perfect. Okay, guys. Well, again, thank you very much. Excellent session. We're a little over time, so again, for those that are on with us, thanks for sticking it through here. We're just gonna, in the interest of that and respecting our attendees, schedules, I'm just gonna suggest we have 2 questions. And again, we will compile everything we've received and provide all answers in writing through the QA report. But for these live discussions, we've had someone chime in and ask about atrial PD loops. And essentially, they're curious, can atrial PD loops be recorded with this type of equipment? And essentially, why would you do this? And actually, I wanted to point this question to Dr. Hamlin because I happen to know you have some experience with it. Dr. Hamlin, are you with us?
Yes. Glad to discuss this. Of course, everybody understands the importance of atrial function, transferring blood and helps keep the venous pressures low. And we want to know atrial systolic and diastolic function, and can use the PV loops for the right atrium very, very easily. It's simple to put a catheter through a jugular vein right into the right atrium, and you get quite nice loops. They're figures of 8, and you can measure systolic and diastolic function differently than you do from a closed ventricle, but from an isovolumetric ventricle. But they're very easy to obtain, and we feel they produce very important information. And everybody knows about the importance of atrial function as well as ventricular function.
Thank you very much. Actually, I guess as a final question then as well, I'd like to turn something to Drs. Emter and Hacker. There was a question specific to both of your case studies where, someone was curious, effectively, if there are other volume measurements that you use on a specific animal model, like instead of comparing groups, whether you're actually looking at volume on the same subject from other modalities. So, whether you are doing that, and, what do you really feel is essential to support your PD loop measurements, if anything?
So I'll take this first. So in the mouse model, it's really hard on the right side is to get a flow probe like some people have done on the left side around the pulmonary artery. And so we've sort of correlated our PV measurements with echo measurements. And it's really difficult for us to do those simultaneously. And so we're not, so it's hard to get perfect correlations, but the correlations we get between those two are quite high, usually around 0.6, 0.7. The absolute volumes don't always match, and we're not sure which ones are farther off, either the echo measurements or the PV measurements, and we're not that concerned about it because we're just comparing values between groups either way. When we've done larger animals like pigs, we've looked at MR measurements and also Swan-Ganz measurements, and again, we haven't been able to do those simultaneous to the PV measurements, but the correlations are good, and we're quite satisfied with the numbers that we get from the PV loops.
Yeah,
okay, thank you.
Craig. We're kind of in the same place as Dr. Hacker's group. You know, we've examined our pressure volume loop volumes in comparison to other published pig volumes, and we're definitely in the ballpark. So we feel confident based on previously published things. We've always kind of done a little slight tweak to most of our experimental procedures, so it's hard to directly compare the studies that we've done. And in some of them we've done CT imaging or MRI imaging, and in others we've done PV loop, just pressure volume loops. But there's definitely been some correlation and similarities enough in volumes that we've seen from multiple imaging modalities in addition to the PV loops that we're pretty confident we're seeing something that accurately reflects what those volumes are.
That's perfect. I'm sure that addresses the question. I appreciate it. Well, again, in the interest of time, I think we'll wrap up this session. Again, attendees will be able to send in additional questions through the window just before we close things down. So I'll leave this session running for the next 5 minutes, providing you some time to send in questions, which will be included in the Q&A report. So in closing, thank you for taking part in this event. We do encourage all attendees to register at InsideScientific.com as a member so we can provide advance notification about webinars and other educational resources. The next session in the PV Loop web series will be Wednesday, May 14th, same time. And this event is sponsored by Indus Instruments and will be including videos and best practices all about proper surgical monitoring and heating during mouse and rat models for best PV loop data. So we think that would be very informative and value for those people that are doing rodent models out there or interested in learning how to do them properly. An additional session will also be following that, understanding the translational value of PV loops from mouse to man, which is sponsored by Molar. So again, thank you everybody for your time today, and we look forward to seeing you again soon. And thank you to all of our presenters that joined us today, Craig Emter, Philip Konechny, Dr. Robert Hamlin, and Timothy Hacker. Thank you, gentlemen. Did a great job, and we'll hope to have you again in a future event.